Okay, let's open up the subcommittees. First up, ambulances. So, Mark, we have these checks that were sent out. Needless to say, I was kind of shocked to see a check that's $5,000. The first question I would be posing on terms of this 5,000 check, it turns out that some insurance companies, and Anthem might be one of them, actually does pay the balance billing. So, in terms of the way you read the statute right now, do you see that means any check that the insurance company sends to the customer, to the patient, regardless of whether it's balance billing or not? Is that what you're looking at? Because that was never the intent of the legislation. Was always, it was in my mind, in my memory, was always just what the reimbursement for the whether the ambulance is in network or not, and that the ambulance company, the insurance company would send the ambulance company the check, and obviously they were my understanding was that they were sending the check to the patient if the ambulance company was out of network. Okay, so the question is, if all we did is say, assuming that it's only the reimbursement for the ambulance and not the balance billing. Okay, because evidently some insurance companies pay the balance billing and some do not. And you pointed out MVP, and by the way, MVP left the state like 5 years ago. Right. So if the issue, if we were going to narrow down the issue, is only the only check that we're focusing in is we're not focusing on the balance billing check. We're focusing on just the check the insurance company is reimbursing the patient with. Then that would be a reasonable, I guess, compromise. Right. The bill, well, at least that's what we think it is. But I think when
Also, the reimbursement check, whatever check they're sending to the patient should be coming to us for the ambulance bill. If it's covering the charge of the bill, it should come to us.
right, but we know that when it comes to all other health insurance costs, when they send a check, they're to the provider. That's based on the contracted price. It's not the full price. So that to keep it apples to apples, then as long as if we write the legislation to say is what the reimbursement, but not the balance billing. No, the balance billing you still have to collect from the patient. We want you to join the network, and evidently for Anthem, there's a huge chunk of there's 100 people, 100 different ambulances that are in network. So that's not a problem. They get a bigger check than
That's why we're not joining. It's not because we don't like them. It's because we can't survive on their reimbursement in an emergency service.
right. I understand. So basically, what we're doing is we want to raise everybody's premiums in the small group market, so that ambulances get to be one thing that nobody else, no other healthcare provider gets, no hospital gets, is the full amount. Is that fair?
So if I understand it, ambulance billing is like 1% of their total output. 1%. 0.35%, sorry, of their whole outlook. So us getting the full check to keep us solvent isn't going to break them. I don't see that at all.
Well, I would have a problem with that. No, I'm sorry. That is throwing the whole managed care, the whole reimbursement
So,
system in the trash can.
You
We
can pay
cannot do
Peter
that.
or you can pay Paul, because what we need to make up in the emergency service is gonna go to your taxpayer, right?
Community.
So
Right.
now you're spreading that one person's bill over the town, right? Not just on that one person.
Let's think about this for a second. What would then stop all the other providers, all the other healthcare, all the other hospitals and doctors and all them to come in and say, well, gee, you gave it to the ambulances. Why can't you give that to us too?
Because
We don't
we're
want to be.
open 24/7, no matter what. They are not. They have patients lined up. They schedule accordingly. They don't wait for calls. They don't wait for patients.
Well, emergency rooms do.
Emergency rooms do not wait for patients. There's
They're-
lines out the door.
No, there's plenty of emergency rooms that are sitting there waiting for people. Yes. Okay, but that's their model. I mean, again, we're talking about the business model.
Yep.
Okay, and you're asking for something as a special privilege to say, well, ambulance companies. So we can't just, some of them are towns, but some of them are not. Some of them are private businessmen. Okay.
Not many.
Well, anyways, okay. The issue of saying is the issue I always thought was the reimbursement rate from the insurance company for the
So
ambulance.
the in-network payment?
No, well, let me just say what way I did understand that there was always two different amounts. That if you were in network, you got a bigger check if you were out of network. Okay? Do we
and
agree
that's-
on that?
And that's fair.
Okay? That if you sign a contract, you're going to get more. Right? So that
Bill-
you're okay with that, right?
No.
You're not
So-
even okay with that either. So you're basically
are
saying
they-
you don't even
so
want
they're
them to
gonna
sign
pay
a
the whole
contract.
bill? Are you
No, well,
saying
you-
they're gonna, if I submit the bill and I'm in network, they're gonna pay me the whole bill? Nope, they're not, right? So it's
They don't pay anybody the whole bill. They don't pay any other profession. Nobody, not even pharmacy, not even doctors, not even
that-
hospitals. Nobody gets the full pay.
because
right?
Nobody's like us.
Okay, Representative Calabro.
I think the quibble here seems to be about the legislation to write something that has been taking place for a very long time, and that is that the fees for service are not sufficient. We're assuming that this status quo is the model you want to continue. And what these towns and municipalities are trying to say, and I've been a part of their volunteer ambulance service in the past, is that they won't stay solvent with these fees for service the way they are, and they're begging for our support. That's what I'm trying to say. Somebody is going to have to cover it at some point, and if the onus becomes these municipalities, the wait times are going to be longer and lives will be lost. Volunteers will not step up. That's all I'm
Okay.
trying to say.
So it doesn't bother you that private insurance company is only 20%. The rest of it is ERISAs, large businesses, Medicare, Medicaid, and it doesn't bother you that we can't force them to pay more. You just want to go after the small businessman, the small businesses. You just think that they're the ones
What are you
who
talking
should
about,
make.
small businesses?
It's okay. What this legislation affects is only small employers and individuals.
What, ambulance?
And the ambulance mandate, okay? We have no legislative control. I know we haven't really talked about this over the years. Usually, in the old days, we used to go through this issue all the time because we used to get a lot of health insurance mandates. We haven't gotten them so much because of the Affordable Care Act saying that if we were to pass a new mandate, the cost would then have to be passed on to the state. Okay, so that's why we have not had this conversation. But if you were to take all the people who are insured out there, okay, you say 100% of the population. Obviously, there's some are uninsured, so we're taking that off. But we have the number one employer-based health insurance plans are called ERISAs, which is created back, Gerald Ford was president, and it's an employer-based health insurance plan. Otherwise, it's known as self-insured. Okay, and the state is an ERISA plan. Some of my county is ERISAs. I don't know, but a lot of large employers are ERISAs. So this legislation does not affect them. They're outside of this legislation. This legislation affects a very narrow group, and that is the small employer,
Understood.
50 or less. So the question is, do you want to make them pay the full amount while everybody else will pay what they feel like paying?
No, I want the insurance companies to do the right thing by everybody.
This is, we can't do anything about that. Okay, so I was just saying is that if we want to get to, the question is that, yes, it is true, we have this cost differential about which ambulance companies sign a contract or don't sign a contract, that there are reimbursement levels different. If we want to write this legislation, which I always thought this is what the issue was about, okay, so this is news to me, that I just decided, asked this question, that they're now asking for the balance billing payments if the insurance company was generous enough to pay that. Because not all companies pay the balance billing. Okay? So if the insurance company is willing to pay the balance billing, should they also be sending that check to the ambulance company or sending it to the patient and have the patient send it because the ambulance company made the decision not to sign a contract? Does that make sense? Okay. Go ahead, guys.
Thanks for the opportunity to speak. Chris Staywas from Hollis. I'm a little confused. Now, as far as I'm aware, this legislation only applies to direct payments that are currently going to patients. Doesn't include balance billing, doesn't include any of those other things. All we are asking to do is to take the name of the patient off the check and put the name of the ambulance company that provided the service on the check and mail it to them. Simple as that.
And you understand that that does not necessarily, if the insurance company were to reimburse the patient for the balance billing, you're not asking for that check.
No. And
Okay.
what we're asking for is budget neutral
I-
because they're already
I-
paying
I-
the amount to the
I am
patient. We're just asking
glad
them
we
pay
got to this agreement. I'm glad you came up here because I know Mark doesn't agree. But at this point, you and I are on the same page.
And as Representative Calabro illustrated, there are other things that we need to work on in future legislation.
Right.
But as far as this goes right now, we're just asking simply for direct pay for payments that are already being made.
Perfect. All right. You would concede me. Thank you.
And
Appreciate
we
it.
still get the ability to balance bill for the rest, correct?
They absolutely have the balance billing list. And we don't want to say that insurance companies can't pay for it. If they do want to pay for it, that's out of the generosity of their own heart. But that's not what we're looking for in
So-
this particular legislation.
So if the insurance company is sending one check with their name to the patient, why don't we just, whether it's the full amount or whatever, direct pay, whatever you want to call it, why isn't it coming to us?
My guess is that this check was the full amount. I mean, I don't know. Maybe it wasn't, but my guess this check was probably the full amount. But at any rate, if we can agree on what we need to legislate on, then we're golden. So now I'd like to have the insurance department. Thank you, Mark. Right. We can have this conversation again offline. Okay. Yeah, you might want to press the button and introduce yourself. Not that sure, almost everybody must know who you are now.
I'm here often enough. Good morning, Mr. Chairman, members of the committee. DJ Betancourt, Commissioner of the New Hampshire Insurance Department, joined this morning by my colleague Michelle Heaton, who is the head legal beagle of our Life and Health unit. Wanted to just take a step back for a moment and provide a little bit of an update on an exercise that we went through as a department this summer and fall, of which this particular piece of legislation was part of that discussion. So as you know, a prohibition against balance billing has been a position the insurance department has held for quite a long time. We see it from a consumer protection perspective, and we think that what happens to patients in these situations is quite unfortunate. But I've been coming to this committee making that argument and haven't gotten anywhere, and neither had any of my predecessors, so it wasn't anything exclusive to me. But this summer, I then saw a story in the newspaper regarding some commercial ambulance providers who were going through major financial struggles. And I thought to myself, maybe this is the opportunity for us to bring all of the stakeholders together and see if we can't come up with a solution that solves this issue from the perspective of the consumer, from the perspective of the provider, and the perspective of the carrier. And so out of that came what I dubbed the Ambulance Summit. And as I said, we met for a good portion of the summer and fall. We brought all of the stakeholders together, and we learned a lot. It was a good exercise, although unfortunately we did not ultimately reach an agreement on what the best solution was. But we did throw out some proposals. We put out some potential solutions. It was part of a package of ideas. One of those ideas, believe it or not, Mr. Chairman, don't fall off your chair, we suggested that perhaps a fee schedule was appropriate. Mr. Conservative here advocating for a fee schedule, but the reality is the two sides are not negotiating. And you're obviously hearing differing perspectives as to why that negotiation is not taking place. So we said, well, let's do a fee schedule as a percentage of Medicare, do a prohibition on balance billing, and address this direct pay issue. So that was one idea. That did not get agreement. So we said, all right, well, we can do a minimum allowed amount. So set that floor for rural and super rural, which is where the providers, particularly in the commercial space, are really having trouble. And again, we'll do the prohibition on balance billing and a prohibition on direct pay. That didn't go anywhere. So we then suggested an IDR process with that floor, again, with the prohibition on balance billing and the direct pay issue. The problem at the end of the day was there is a fissure in the interests between the commercial providers and the municipal providers. In each and every one of those solutions that I just presented to you, the providers would have gotten additional funding, would have gotten more funding. Was it everything they wanted? No, it was not everything they wanted. And I will say, to the carrier's credit, each and every time we've put one of these solutions on the table, none of them ran out of the room. They were all willing to negotiate. They weren't in love with it, but I don't think that they particularly liked the status quo either. So unfortunately, as I said, we weren't able to come up with a solution that was universally embraced. But what I will say is that the federal government is coming. They have not forgotten that there is this gap in the No Surprises Act with ground ambulance. And I don't know what their solution to this is going to be, but I think in the New Hampshire tradition, we would much prefer to have our own solution that is attentive to the needs of this state rather than having the federal government impose whatever it is that they're going to bring forward on this. So that's a little bit of the context and the history that I wanted to provide to you. I will say I have a great deal of concern for the commercial ambulance providers. That's not to say that I don't have concern for the municipal providers, but the municipal providers at the end of the day have a backstop. You and I, and the fire budgets that our communities ultimately pass and ultimately we as property taxpayers pay for. The commercial providers do not. And those are the entities that I'm very concerned about. And as I said, it was unfortunate we couldn't get to an agreement, but there are solutions out there. And I think that as you approach this, you want to do so in a comprehensive way. So those are my thoughts. Michelle, anything to add?
Just with respect to direct pay, that is kind of one of the bargaining chips. So if you allow them to get direct pay now, there's less of an incentive for them to come to the table and negotiate out these remaining issues. And at the end of the day, it's still allowing balanced billing. So when we hear all of these stories, I think probably everyone in this room has heard a story about someone getting billed, $10,000, $15,000 when all the ambulance did was take them from one facility to another down the street, or it was an emergency call right down the street. Those stories are what's impacting consumers. And when we're talking about consumers, we're talking about, like Representative Hunt said, those that are purchasing commercial insurance in the individual and small group markets primarily. There are some large group, but most large group is self-insured and outside of our jurisdiction. And this bill is not going to fix that for them. They're still going to get that bill for that outstanding $9,000, $8,000 that the consumer is legally liable for. So, as Representative Hunt phrased it, out of the goodness of their hearts, if the insurer decides to cut a check to the consumer, that's great, but they're not legally obligated to do that. And until we come up with a solution that prohibits balance billing in some way, it may not address everything, and it's going to be a work in progress, but the first step in the right direction is to prohibit balance billing.
And I would just say to that too, as Representative Hunt highlighted, the New Hampshire Insurance Department only regulates approximately 30% of the health insurance market in New Hampshire. The rest of it are the government programs, Medicare, Medicaid, and then the self-funded plans are obviously outside of our jurisdiction as well. What I will say is, I firmly believe that the status quo is unsustainable for the providers and for consumers. I'm happy to continue the conversation with all of the parties and stakeholders to try to figure out what the solution is. But I will say that even if you pass this bill, it is not the fundamental reform that this system needs.
Great. So the question I have is, do you have a copy of the bill? So if we interpret this bill is that it's not about balance, it's not about the balance billing or receiving or check writing. It is simply because it says subject to the terms and conditions of the policy plan, that we should just go ahead and pass this bill, which just removes the check payment, still will go to the ambulance company, but that check that's going to go through to them is based upon whether they're in network or out of network, and what the insurance company was reimbursing based on those conditions.
So if they're in network, it's already going directly to the
Right. So
provider.
that's right.
If they're out of network and you pass this bill, that means the allowed amount, the amount that the insurer says is commercially reasonable for the rates being
Right.
for what's being charged, that check would go directly to the provider.
Correct.
And then the balance billing check would go back to the consumer.
If they
once
so
it's-
generously do that.
Yes, but doing that provides less incentive for the providers to come in network, because now they don't have to get that direct pay.
But the check is going to be smaller.
Yes, significantly smaller.
And then they've got to struggle to go get that balance payment.
Yes.
So it's not, I mean, you could say there's some disadvantage, but there's a little play in there that might make it work. And so I guess that at this point, I would be willing just to pass this as written, unless someone can stridently tell me this is a bad idea. Yeah.
Thank you. So this is just for a small segment, as we discussed. So the rest of the percentages of the different tiers of insurance, what happens to that quote balance bill?
The consumer will still get the bill from the provider and still be liable for paying that outstanding amount. So just to give some perspective, we use Medicare rates kind of as a base mark in a lot of health cost stuff. So right now, and it really depends on the code and whether you're rural, super rural, urban. So there's a lot of varying factors, but most allowed amounts are around, 120 to 150% of Medicare. What's being billed sometimes is over 700% of Medicare. So that larger amount is what the consumer is still going to be liable for. So if the consumer takes the check, cashes it, and then doesn't pay the provider is the one that needs to go after the consumer. And that's where this problem is, because the providers either don't have the bandwidth to do it, or they don't want to because it's, their neighbor or something. This doesn't change that problem at all. And that's the majority of the money we're talking about.
Okay. Representative Burrows.
Okay, so I guess my question is, so the commission met over the summer and in the fall, and so we still we do not have a consensus. So is your feeling that we still should not pass this bill to give relief and waiting for Godot, I guess, to fix it? Does it? He doesn't?
No,
Okay.
Godot never showed
Oh,
up.
I didn't realize that.
Look, whether or not to move forward with this legislation is a policy call. That's for you to make. If you're asking my opinion, I think in order to address the issue as a whole, you're going to want to move forward with something a little bit more comprehensive, of which this would be an integral part.
Follow up. I this is a would you believe, would you believe that it's going to be a very long time before we have a comprehensive plan? And I don't see a problem with, if there's, in this case, the ambulance providers are really hurting, could go out of business. I don't see a problem with addressing a piece of that until we have the comprehensive plan.
Well, I would just say I don't know that I would completely agree with that, because as I said before, you do have the fact that the federal government is working on a proposal right now to deal with balanced billing on ground ambulance. Senator Prentice is very involved with that effort. Their proposal is currently proprietary, but at some point it is going to come forward. I don't know what that will look like. As I said before, I think we want to have a New Hampshire solution rather than a solution imposed upon us by the federal government that may or may not work. And look, as I said before, the proposals that we put forward didn't get consensus, but at the end of the day, all of them provided the ambulance providers with additional financial support. So that was forward progress. The problem that we seemed to run into was that for one provider or another, it wasn't enough. It wasn't sufficient to cover all of their costs. Well, my view of it was, well, let's make some progress on this. Let's get you some more support, and we can keep working on this in the future. But that unfortunately fell apart.
Well, some people might say that we're putting off, by passing this bill, we're putting off the incentive to get the issue solved. Well,
I would also add, though, that some providers I'm not providers, sorry, carriers are directly paying already. So they have the option to direct pay or to pay the consumer. And not everyone is paying the consumer. So I think overall, they're not going to see much, I'm speculating here, but I don't think they're going to see the relief they're expecting by this bill passing.
yes, Representative Shelley.
So this bill will not do any harm. It might move the ball forward incrementally, but we all see it as an issue, but what will it take to get the conversations going again and making sure that we could keep making progress? No is not an answer.
I think the big sticking point that we're at is this philosophical divide as to the underlying issue of commercial insurance can't cover the full cost of providing emergency services. So who's going to make up that gap? Do you want to raise rates on commercial insurers to bridge that gap? And doing so could cause upward pressure on insurance premiums. And the people paying those are people in the individual and small group markets predominantly. Or is it up to the taxpayers to bridge that gap? And I think that's the fundamental divide. If we had a decision as to who should be paying that, then we have a way forward. But right now, it's all over the place. Some people think balanced billing is great and that the consumer who uses the services should have to pick up that gap in money. Others feel that it's the commercial insurers who should be picking up that tab and bridging that gap. And then others feel that it's the communities. The communities decide what is appropriate emergency services and how much they want to spend on funding that. And they're the ones that should be bridging the gap. So that fundamental issue right there is what causes us to not get consensus on any of these smaller pieces. If we had some direction that way, then I think it'd be easier for everyone to come to the table and we could say the legislature has said this is how it should be funded, so let's work on that aspect. But I don't know how you go about doing that other than
Yeah.
making a finding.
In
or
my
something.
in my perspective, the problem is Medicare. Medicare is the lion's share of ambulances, and Medicare is the one that's not paying enough. And even if we were to just say, okay, we're going to make our base the individual insurance equal to what Medicare, well, they're already greater. So yeah, it's Medicare is where the money needs to come from, and yes, that's federal government, and yes, they did it for everybody. They did balance billing for everybody, including helicopters, but they didn't do it for the ground ambulance. So, okay, thank you very much. How does everybody want to think about this before we take any action, or people want to just run with this amendment? The bill as it's written, or should we make sure it really says what we think it's supposed to say and take a subcommittee, or should we wait?
No, take it.
Okay. No, excuse me, no amendment. This is the bill. We're going to vote the bill as is. As is. Okay. Anybody have any reason why we should not vote this bill as is? Speak now or forevermore hold your peace. Okay. So who do we have?
Terry is not here.
That's a matching. Okay. All right. So it's Hunt, McGee, Porcelli, Burrows, and Calabro. Okay. All those in favor of, I'll make a motion of ought to pass. Second. Okay. All those in favor of ought to pass, raise your hand. 2, 3, 4, 6. So it'd be 6. Who's not voting? 1, 2, 3, 4. Oh, wait a minute. Yes, you only have 1, 2, 3, 4, 5, 6, 7 names. Who's missing in that list? Okay. All right. Anyway, we got a vote. We got 5 votes. We're good enough. 5-0. When we had, but you said Terry, but Gibbs is not here.
Gibbs isn't here, and Vince
Terry,
is
so
not
that's
here.
7.
And Terry's not here.
Right. Okay. And who was the other person? Oh, Vincent. Okay, so we were missing a Democrat. Okay, we're fine. No, we don't. We're all set. We got 5-6. Okay. All right.
5-0.
5-0. Okay. Okay. 1296. So we're waiting for a fiscal note on 12. Is that what we were waiting for? A fiscal note on 1296?
Hi, Michelle Heaton,
Yeah.
New Hampshire Insurance Department. We did submit the fiscal note to OLS last week, but I'm sure they just haven't gotten around to
They haven't gotten around to
finalizing it and getting it out. So I do have a copy of it here if you'd like. I
Okay,
can,
sure,
pass
we
it
can-
around. So as those are going around, I can kind of summarize things
Yep.
a little bit for you.
Great.
There will be some impact, but at this point, it's indeterminable. We don't know how much. We think it'll be relatively low. Part of the problem with this is that this is with respect to cost sharing. There's a lot of variables when you're trying to predict cost sharing because it depends on the individual's plan, and we don't know who's going to need these services and what types of plans they're in. If they have a platinum plan, their cost sharing is a lot lower than someone with a bronze plan. So it's very hard to estimate the impact here. But we did do some, we looked at some CHIS data for these types of services. And overall, most of these are provided with little to no cost sharing. And I believe, let me jump in. So the mean cost of cost sharing for these services was non-zero but trivial. Across the 3 most commonly billed diagnostic mammography services, and those are the codes there, we had 34,000 codes, which is a lot lower than all of the mammograms being conducted for commercial insurers and managed care organizations. The median cost sharing was 0. So that means that most of them have no cost sharing. But for some diagnoses, we observed a non-median cost value of less than $100. So the cost sharing was under $100. The median cost sharing for those who had cost sharing was under $100. And that's about 0.03%. So overall, it's going to be a small impact. But again, estimating cost sharing is very hard to do, especially too, you have to think of the out-of-pocket max. So if someone has a $5,000 out-of-pocket max for their plan, which is actually kind of low, if they've already spent that $5,000, then they don't have to pay any cost sharing for this. So depending on when someone got the services, if it's later in the year and they already met their cost sharing, they may have nothing. If it's earlier in the year and they have not met their out-of-pocket max, then they may need to pay more. So that's why it's very difficult. There's a lot of different variables here, so it's very difficult to assess the cost of it. So I'm happy to answer any questions.
Okay, well, the bill says no deductible.
It says that it wouldn't be part of it. You can't apply cost sharing to these services.
Exactly.
Yes.
So if someone had a 5,000, then that would mean
No,
it would cost the insurance company they would have to pay the full amount.
Well, it would depend on your out-of-pocket max for your plan and whether you've already met it. That's
but
with estimating the overall cost for this. But we see the median of those who pay who have cost sharing associated with it as being less than $100 for these specific services.
Right,
But
the
that's
cost
very
share, that's
variable.
the deductible you're talking
Not
about.
necessarily. It could be, co-insurance, co-pay. They haven't met their out-of-pocket max, or maybe they only have a small amount left to meet their out-of-pocket max. So there's a lot of different variables that make it difficult to
Okay,
estimate. what this
I
is
guess
gonna be.
I'm still fuzzy. Let me make sure I understand. Okay, I have a $5,000 deductible, right? And this is the only thing not me, my wife. Okay, this is the only thing my wife needs is this thing. And we see that it costs like $2,000 to operate this unit. Okay. That is not $100. That's $2,000 that I have to pay. The way I read the bill, and I'm trying to find my copy of it, is that $2,000 will get waived.
Yes, if your plan says that for these services, you have to meet your deductible first. If there's a copay or co-insurance associated with the service, you'd only have to pay the copay or the co-insurance until you meet your deductible and out-of-pocket max.
That's the way the bill's written.
Yes, so it would waive any cost sharing, and it would depend on the plan design to determine what that means for each person. And there's a lot of variability in plan design. That's why it's very hard to estimate the physical impact of this if it were to be enacted. But based on the claims data, we're estimating that'll be relatively low, but there is an impact.
On the current claims data,
Yes.
but on the current claims data, the deductible is being paid by the patient.
Yes, if that's what the plan design. So your plan could say that
Right, but we're more interested in what happens if we pass this legislation where it says the deductible is no longer, that the patient doesn't have to pay the deductible.
yes.
So how much is that going to be?
And that's what's hard to figure out because every plan will charge a different amount. So if it goes to your deductible, then yeah, you could be stuck paying that $2,000 and this bill would fix that so you don't have to pay anything. For other people, it could be $50 copay for this service. So now they don't have to pay that $50 copay. And
50 is nominal. Right. I'm
so based on
focusing in on people who have high deductible plans.
yeah, so then it
And
would
that's
be a higher impact for
and
them.
that 2,000 grams and then so the guesstimate is how many women on an annual basis would have just saved the $2,000 if we pass this bill.
Yeah, and that's very hard to determine because we don't know how many of that would take way more analysis to figure out
Okay.
what kind of plan the people getting these services have. High deductible health plans are usually for younger people who are relatively healthy. These services can apply to anyone at any time in life. So it's very hard to estimate that. And it really is dependent on the type of plan you have, how much of an impact this bill would have on them.
Okay, Representative Spear.
Thank you. At the first meeting we had on this subject, we were given information in the typical way that I have. I, of course, verified all of it. There are quite a few states that already have passed this kind of legislation. And we were given a stack of analysis about that thick, showing us what the type of analysis that went into the cost increase for Massachusetts. And it was very, very detailed, and it came down to 13 to 33 cents. And it's been enacted, it looks like, about 18 states. It seems to me that the data does exist for you to figure this out, at least at the level that Massachusetts figured it out. So I would think, if you need this, I'd be glad to give you my copy of it, that there is a way to get this information. It shouldn't have been that hard, I would think, because it already exists.
What we can do is, and this would be a much more detailed analysis that would require a lot more time and may need an outside consultant to help out with. So that would be different. I was suspecting it was a mandate analysis, and usually in states when they request that mandate analysis, it's actuaries get involved. It's a lot more detailed.
Right.
But we won't be able to estimate moving forward with too much specificity because it really depends on what type of plan the person has. Massachusetts is not always analogous to New Hampshire because they have Mass Health and they have a lot of different other programs. Their market's very different than in New Hampshire. So you can't use that necessarily as a comparison. What we did is we looked at the last year of claims data that we have for these diagnostic codes. What was the median cost sharing? And the median cost sharing is 0. So it could be that there's no cost sharing because these people have already hit their out-of-pocket max, so they're not incurring any cost. It could be that they have plans that cover these without coinsurance. There's a lot of different variables that go into play. So without doing a deep dive into this data and figuring out what kind of plan did these people have, why is there no cost sharing for them, and then why are of the people who did have cost sharing, why is it under 100 the median for that? Some people definitely did pay more, some people paid less, but there's a lot of variability here. So we can look back at our claims data and try to figure this out, but even in Massachusetts, it seems like they gave a range. So we're saying that this will cause an impact on premium. Well, not necessarily on premium. Insurers will have increased health costs, and we think it's relatively low increases, but we can't give much more specificity without doing a much more detailed study.
Right. So, yes.
I just had a follow on. Based on what I see, the range of states are states like Montana, Colorado, New Mexico, Arkansas, Missouri, Illinois, Tennessee, Georgia. Between all of those states, we can't find a state that is similar to ours.
No, because a lot of those states have larger populations. The dynamics of their markets.
I know
much
Montana
different.
does
Yeah.
not. They're half our
No,
population.
yes. But the market, how many players are in it, what type of mandates they already have in place, all of these things factor in, and you would need a much more in-depth study to figure that out, which we could do. We have the ability to do that as a mandate study, but those studies typically run us between $22,000 and $44,000 to complete that study.
Right. No, we've already talked about this already. I don't know if you were here when we did this last week. Okay, so the mandated study is something that's been on the statute for about 15 years, and that whenever we get these health insurance mandates that we really don't know what the impact is that we have done the study. In that study, you set up parameters about what is it you want to look at and what we're thinking about. But in my mind, the big issue is that how many employers in the state actually have a very high deductible plans, because that's really what drives it, is the employer who is buying the policy for the employees. If the employers, and I guess I'm guilty as an employer, I have a high deductible plan for my employees, and So in my case, it would be different, but I don't have a woman on my as an employment, so it's not an issue. Okay. So notwithstanding that, the high deductible is that the question is, does New Hampshire have a disproportionate amount of high deductible plans? Okay. The other issue in my mind is that you don't want adverse selection. We want people to choose the plan that is right for them, not because whether the high deductible or not is going to get covered for a certain mandated coverage or not. So that's always been my loose end when it comes to these high deductible plans. But in this case, so that we would be asking the way you would do it is we would interim study the bill. We would be asking the department to do a cost analysis, and then come next January, we would then have that in hand and then make a decision on what is the best way to go forward with this
This is a
legislation.
procedural question then.
Yep.
My understanding was on an interim study bill in the second year, it's just going to die. It isn't going to go to any kind of a vote.
Well, what happens is next year, okay, is that every bill can come back again.
Oh, so he's talking
that
about
are
coming
dead.
back.
So somebody would reintroduce the bill next year, but in that public hearing and that reintroduce it would be that analysis.
The problem I'm having is that we have enough information, and I did my own little research in that way that I have, that there are too many states that are doing this to just keep putting it off, and that women are being impacted. I think that there is enough data right now to say that we can do this or not do this.
Okay. Representative Burrows.
Thank you. I'm just wondering if there's an industry person who could speak to this, who could tell us why this is or isn't a good idea.
Industry being,
Somebody who supports the bill.
they were here before, but yeah,
I know.
they're in the background.
Okay.
Right. Well, yes. Why don't you come on up and you're a sponsor of the bill, right? Yeah. So the question would be is how many tests could this cause? In other words, if it's a one-off, that's not a big deal. If it's one of the issues we had was we were discussing last week was that theoretically it was going to go on for another 4 years. It would be the free test.
Yes, I guess I would suggest 2 points that I don't believe we need an analysis at this point because it has been done in other states. It is an expensive undertaking. We already have heard and understand that it is a limited cost we're looking at. The particular point I wanted to make is just to reiterate, this does not apply to high deductible plans. You would have to pay your deductible before this bill would
no,
have
but
effect.
it does say it does apply.
There's an exemption in there. I'm sorry, I don't have the paper in front of me. I should have brought it up with me. But
If the deductible is the only issue I have, the copay is nothing.
so to take your example, if I understood you correctly, as the employer with your employees having a high deductible plan, they would have to pay their deductible before this bill would have effect.
Okay, so where is that in the bill?
Thank you.
Is there no group? Oh, you know what's weird? You get the definitions before the statute, so maybe it's
an ordering issue that was a
Yeah,
little bit confusing, perhaps.
okay. No group health insurance offer group.
Thank you. Yes. I'm looking
Any
at the line
cost
8.
sharing requirements.
Yes. So line 8.
Okay. Oh, it said all right. For
For
a
a health-
healthcare contract that meets the definition of a high deductible plan set forth, this requirement shall only apply to the employee satisfying the minimum deductible for the year, except what's
Other than the mammogram, or what I believe is the next phrase. But
okay.
the point being that you still have to meet your deductible before.
Okay,
This
great.
apply.
All right, great. Thank you. So now the insurance department. Does Roman numeral 2 really say when the definition? What's the definition of a high deductible plan? Do we even have that in our statute?
It's defined federally, and I'd have to look it
It's
up
like
to
it's a
look
federal
exactly
rule
what.
here, yeah.
But these are high deductible plans are designed for younger people, and the idea is you pay lower premiums because
Right.
you're relatively healthy and you're
Well,
risking
I'm one of them. I'm
that you're
an
not going to have
employer.
much out-of-pocket
Okay.
costs. So
So I'm
that's
an
why
employer.
it's a very high deductible.
What's the
I'm not
threshold?
sure that employers, and I'd have to look that up. I'm not sure if employers can buy high deductible plans. It's a special type of plan. It's not just a plan that you would, relatively speaking, think have a high deductible. So you could have a plan that has, you know, a $10,000 deductible in theory. That's not the same as a high deductible plan. High deductible plans work differently. And under federally, those are, there are certain preventative services that at the federal level have to be covered without cost sharing. That applies to the high deductible plans. But for this bill, it would not apply to those federally defined high deductible plans, which is a separate type of plan.
Right. Okay. You found it? Okay.
Yeah, so it says, the reference definition is 26 U.S. Code,
Yeah.
section 223, right? So it says for calendar year 2024, a quote, high deductible plan, unquote, is defined under 223C2A as a health plan with an annual deductible that is not less than $1,600 for self-only coverage or $3,200 for family coverage, and for which the annual out-of-pocket expenses, parentheses, deductibles, co-payments, and other amounts, et cetera, et cetera. Hang on. To be the rest of it.
So that it's
That's the
1,600 for an
different,
individual, 3,200. So as an employer who has a $5,000 plan,
but not premiums. Okay, so for which the annual out-of-pocket expenses, deductibles, co-payments, and other amounts, but not premiums, do not exceed $8,050 for self-only, $16,100 for family.
$8,000.
That was no, that's out of pocket minimum.
That's
so that's not the deductible. That's the out of pocket, right? So there's
the out of pocket.
deductible
That's
and
what
out-of-pocket.
I'm talking about. Is when it's talking
Well,
about famous EOBs, right? Explanation of benefits.
Yeah.
And when we get those, and they're going to say, you know, how much the insurance company is covering, and how much I have to cover, but that I have, if I have a $5,000 deductible, that means I've got to pay. I got to pay that excess amount up until it reaches the full 5,000.
No, deductible and out of pocket are different. So deductible is like
Excuse
you
me.
pay the first amount and then
The deductible is usually $50, $100, nothing, nothing to
That's
lose.
copay.
depends.
Copay,
No,
excuse me.
copay,
Excuse me,
I would
copay.
say is different.
Right, copay is it's the deductible that can be the high amount.
Then there's the out-of-pocket max, which is the total. So you
The
may need
out-of-pocket.
to
Three
meet your
different
deductible, and then co-insurance will kick in until you meet your out-of-pocket max. So for high deductible, they're a separate type of plan, and they have other requirements. But the out-of-pocket max, I believe you said, is 8,000 and 16 for the individual and 16 for
And
family.
16.1 for family. So that's
But they operate differently.
that includes everything, like even your $25 at CVS to pick up your prescription.
Okay, so this
So
is
for
a
those
very
plans-
narrow
Carved
little
out.
exemption that we don't.
You
who
need
knows-
to have that to so that the plans comply with federal requirements and IRS requirements
We
for
would have to-
that type of plan.
Okay. I guess I'm what I'm just trying to get at is what is available. What are people buying in New Hampshire? And when
You can buy these, but I think
like I have a Harvard plan for my employees, and I guess I would ask you, Peter.
so.
Given that I have what I call the high deductible, I'm in the small group market. I'm paying the lowest possible premium, and I have the highest possible deductible.
It's not necessarily a high deductible plan. High deductible plans work differently. But
Okay.
Dr. Az is here, and he did the analysis of the CHIS data. And I believe, correct me if I'm wrong, Jason, but when he was looking at it, it didn't look like anyone that had these high deductible health plans had any of these services in the last year. So because they're usually more younger, more relatively healthy people that are buy those types of plans. Because
Okay.
you're responsible for paying most of your healthcare costs until you meet that out-of-pocket max. Where the more traditional health insurance that you're thinking of, HMOs, PPOs, the insurer is paying parts of it until you reach your out-of-pocket max, and then they cover all of it. So it's a little bit different, and that's why you would have lower deductibles if you have higher cost sharings. If you have higher deductibles, then you're usually going to have lower cost sharings.
Okay. Okay. So you think this is not going to cost much?
Relatively small.
May I just add the postscript for what we are hearing will be a relatively small impact. An $80 charge for a patient who's not going to have follow-up is going to have huge ramifications, and we have heard testimony to that effect. I think you got some emails this week. So what is a small cost, perhaps, or limited cost overall to insurance is a huge impact on patients and all of us down the road.
Okay.
Get off my soapbox now.
All right, great. So, thank you very much. So Heidi and Sabrina, you guys want to tell us if you know anything different in terms of what this analysis is and that this is not going to have a big, huge impact on insurance premium? Heidi?
Good morning, Mr. Chairman, members of the committee, Heidi Kroll with Gallagher, Callahan, and Gartrell on behalf of AHIP. So I don't have anything to add to. I don't have any insights into the cost impact. I would say that on the high deductible health plans, I know there's also the health savings account has a piece to that, I thought, in terms of IRS that if you violate the definition of a high deductible health plan, then the tax advantage of the health savings account is put into jeopardy and you potentially have the patient is left with a liability. So I don't know how that all fits into what you just heard, but it's just another, for example, I know where I work, we have a high deductible health plan with a health savings account tied to it. So
your employee,
so
might be impacted by this USC section 223C.
right. That part. And then the other thing I guess I would just say with respect to the, any sort of in the current situation where people have bills with providers, to the best of my knowledge, most providers will work with people to have payment plans. So I just wanted to put that into the people, if in the example that was given that, paying $80 out of pocket at that particular moment is not feasible. To my understanding, most providers are very willing to come up with payment plans. So,
Right.
which would help spread it out at least. So you're not
No,
being
no,
hit
just
all at
the
that
co-
once.
that's just the copay. The copay. Yeah.
So,
Okay.
thank you.
All right. Okay. Because I know we have. And then the other one was the diabetes, the monitoring devices for the diabetes. But I think that one we were talking about going into doing the study to find out what that was. That one we talked about. We need to do the study. So, okay. So, if people want to pass this bill, thinking that it's not going to cost much,
Here's page 2.
okay. So, Representative Burrows, seconded by Representative Hunt, moves ought to pass. Any discussion on the motion? Seeing none, all those in favor say aye. 1, 2, 3, 4, 5. Right, at this moment we're 5-0. Okay. Okay. All right, moving right along. Next up is 1225, conflict of interest. So, our understanding is that there was a conflict of interest did already come up with this board, and that person did resign. Anybody here involved in this issue? Nobody in this room? That you can confirm that did happen. So at this point, I'm not sure there's really a problem here. But I guess we could do an interim study so that in case a problem does come up, we can then do something in the future. Is everybody comfortable with doing an interim study? All right. Yeah, the amendment was insane. Sorry.
So the recommendation is interim study?
So then the next one, the glucose. So I think you did send me what we should be asking for a glucose study.
Yes, I sent you an email outlining kind of how the studies work. As I mentioned before, usually we consult with outside experts on this, and some of these studies can range between 22,000 and 44,000. We also outlined how we believe the study should progress so that you have the best information on how to attack this issue. And I have Dr. Aziz here who can talk a little bit about how that study was designed.
So do you have to? Yeah, so normally with some of these mandate studies or quasi-mandate studies, we try to do a few things. I talked to Michelle to find out what does this bill aim to do. That's usually with regards to expansion of the eligible population and or expansion of the covered benefits and any cost sharing implications. So we usually look at that in terms of different domains, the size of the new population, the size of the new benefit, and any other economic implications for the different parameters of cost sharing. So when we say cost sharing, we're talking about deductible, copay, and coinsurance collectively. And so that's generally the analytic framework that we use to do a claims analysis for any purpose, including the fiscal note worksheets.
Okay. Any questions from committee members? So just to outline, obviously we have type 1 and type 2, and then we have the GEO something,
GDM, right?
which is what is
Gestational diabetes.
gestational.
Yeah.
I always
then
I see
there's-
that sounds like pregnancy to me, but
It is.
shows you how.
It
So,
And hypoglycemia, I believe, is also a subclinical diagnosis included in this legislative language.
Right.
Yeah.
okay. So and then in terms of the pregnancy one that just says, is that after a point in time then they won't need it anymore, or
Yeah, it's not.
so
well
it's really
defined.
we're just covering while they're pregnant to make sure that
and
they're monitoring.
Oftentimes the 12 weeks subsequent to delivery.
Okay, so it's just call it a year. Okay. All right. Is
So
any-
yeah, this mandate report, if you asked us to do it, we would look at each one of these eligible populations and
Right.
what that would mean for providing these services, any increase in premium. We'd also be looking at the utility and medical efficacy of whether these populations can benefit from having these devices available.
Okay. Any other questions from committee members? Okay, so I would move interim study.
Chair?
Yes.
At the
Peter-
public hearing, you had asked me to get some information. I don't know if you.
Oh, great. What did you get for me? Get for us?
I think one of the Thank you, Mr. Chair. Peter Bragdon, representing Harvard Pilgrim Healthcare. As you may know, the state's only non-for-profit health insurance company. And you asked me to get a couple of things, but one of the issues was, and I think it was Representative Terry may have asked, but we were told that this same legislation appears in numerous other states, including Rhode Island. You may recall that. And Representative Terry
Yes.
asked me, "Don't you guys cover Rhode Island? So can you tell us what your experience has been? Because this certainly can't cost a lot of money if Rhode Island is doing it." So it turns out the Rhode Island bill is nothing similar to this bill. It requires coverage for glucose monitoring devices subject to all prior authorization and cost sharing limitations of existing policies on existing. This bill removes all prior authorization and all cost share. What we have now is what the Rhode Island bill mandates that they cover. We already cover it. The issue we have with this bill is this bill takes away prior authorization and takes away any cost sharing. Which I think as the department does its cost study, make sure that's included, because without the prior authorization, then and the testimony was that continuous glucose monitoring systems cost $500 per month, and there's 100,000 diabetics in New Hampshire. So you do the math out, and you're talking $600 million of expenses. So, the key difference, as I was asked to find, is this is nothing like the Rhode Island law.
Right, because of those limitations which
Yeah.
we just had in the previous bill.
Correct. I was also asked what the medical guidelines were for Harvard for continuous glucose monitoring. I can send that to you all. It's probably 8 pages. But then the process, the other question I was asked is, what are the process for determining medical necessity guidelines? And at least within Harvard, there's a panel of medical directors, all of our medical directors of the different branches get together. There's also members of staff for legal staff, for instance, and things like that. Only the medical directors have a vote, but the other staff can provide input. And then they rely on subcommittees, and there's a subcommittee for every individual practice. So in this case, there's a advisory committee or advisory sub. It's not even a subcommittee. It's made up. The policy approval committee is all Harvard Pilgrim employees, licensed medical directors who are employees. Their full-time job is to study everything that's going on.
Cool.
Then they rely on advisory committees made up of practicing physicians who are in network. And they have to meet at least annually or more often if new technologies come in that may require some more look. And so we have a provider advisory group on endocrinology, which is the study of the hormonal system, production of insulin, et cetera. They make recommendations to the policy approval committee. And again, only the doctors on that committee actually have a vote as to what happens. So the legal people can advise them about all that's going on, but the doctors are the ones that vote on it. So that's kind of a background. I wanted to put something in writing, and they said, well, we'll have to have our legal department review that. And I said, okay, we don't have 6 months to wait for that. So that's kind of the overall background.
So we just have to tell everybody to watch this YouTube.
Yeah, well, I did. I said, I'm going to say it, and it's on YouTube. So that's my understanding of it as an overview. So I will send around the document on.
So you're saying that the Rhode Island law implemented something that's everybody was already doing.
Yeah,
anyway.
mandates coverage of the things we already cover. What this bill does, it says you have to cover all these things. Oh, by the way, there's no prior approval requirements.
So
and there's no
so
cost.
this bill does go further than that in terms of gets rid
lot
of all the mandates and all
further.
that. Right.
And again, it's the cost thing that's cost going to come somewhere. It's going to come from premiums, and at some point, people can't afford the concerns they have. So.
Okay. So why did they pass the bill if everybody was doing it already?
Sometimes as a former legislator, I recall things coming up, and it seems like the right thing to do, or maybe you don't know it's already being done. So, or maybe you don't believe it's already being done. So,
Okay. Or maybe it's really old and people weren't doing it back then. Maybe
Could be.
You don't know how old the statute is. You
on
didn't
Rhode
see
Island,
it.
I don't, but I can
You
find
can
out.
Figure out whether
Yeah.
that, because it does seem a little weird. But okay. Anybody have any? Yeah. Uh-oh. Turn your mic on, Chris. Turn your mic on.
Now I've done it.
So the restraint on having $600 million go out the door is prior approval. Is that the basic restraint?
No, the cost of the equipment.
Well, the cost
Well,
of
if
it,
you say
the
you can't
prior
have
author-
it, then you don't have to pay for it.
Yeah, and our prior authorization, well, I got a few copies. I'll just pass it around.
Prior authorization, yeah.
Yeah. Which I'm sure were similar to ours. And I'm sure they have external grievance too.
Yes, and so a good thing to remind you is that if a prior authorization is denied
Right.
because the provider feels that the particular situation is different in some way, then there's an appeal process that goes through both the both Harvard program as well as through the insurance department, I believe, if that's not satisfactory. So in this particular one's a little confusing because it covers a bunch of different plans in different states, but the main piece is probably the critical piece for New Hampshire is on halfway down the second page, and it just lists out the criteria to use for continuous glucose monitoring. So number one, it has to be prescribed by a professional provider in order to be considered medically necessary. If it's medically necessary, it's approved automatically. So in order to be continued medically necessary, it has to, number one, be prescribed by a professional provider with expertise in treating diabetes. Secondly, the member has to be on a treatment program already. And again, if the cost of the monitoring strips is $20 a month and the cost of a continuous glucose monitoring system is $500 a month, they're likely going to want to start with the least expensive options to see if they work, but at some point they don't work. And I think there's a line in here that says that just at times the the self-administration, self-monitoring doesn't work. And so other things are necessary. So these things are put together by the medical guideline committee with the advice of, in this case, the endocrinologist advisory committee to apply. So
Well, it's great. It's always good to look under the hood here
I'll
and
give you
see
some
how
reading, so.
the medical directors operate.
But be
at
careful
Harvard.
when people testify and say, oh, they're doing it in this state, they're doing it that state, or 7 other states are doing this. They're all doing something different. So in this case, the Rhode Island is not a good example.
The variation, yeah.
Yep.
Okay. Yes, Representative McGinn.
Thank you, Mr. Chairman. Could you comment on the professional short-term CGM? So you've got it at 7 to 14 days.
The only thing I know about that is that, so there's 2 types. There's one, a professional short-term, where the provider wants to get an idea of what's happening versus a long-term thing to actually help the member manage their system. And so I think the short-term one is covered no matter what, to allow the provider to have the data they need to make a decision.
For gestational, that's what I'm wondering is if we expanded that 7 to 14 to a little longer in the case of gestational diabetes, which
There may be a separate piece in here for gestational diabetes too. I'm not sure. It's beyond my expertise. I was asked to get a copy of it, so I've exhausted my knowledge of.
Yep. Okay, thank you, Peter. Okay, make a motion, seconded by Representative Burrows, to interim study and do the mandated cost analysis as outlined. Yes, as outlined. Okay, any discussion on the motion? You want to make it, or you want me to make it? Yeah, I'm making the motion just to move things along. Any discussion on the motion of interim study? Seeing none, all those in favor, raise your hand. 1, 2, 3, 4, 5. Okay. Great. All right. Let's go into life insurance, relative insurance coverage for living organ donors. How did we leave this bill? Cancel.
this will simply prohibit insurance carriers, life insurance carriers, from denying you summarily if you've chosen to give a kidney to your brother or sister or tissue donor, or I mean, or the other criteria set forth here.
Does insurance companies actually do this? Do that?
Yeah.
Anybody here?
Sometimes in certain cases.
Insurance department?
Shall he in-house law legal counsel?
Yes.
So when we're talking about life insurance,
Yes.
there's a lot of things that can be considered that you typically would not be able to consider.
Underwriting
Under
is
health
fully
insurance.
permitted
Yeah.
in spades when it comes to.
So if there's actuarially statistical information
If
that
they can
suggests
document
that
it.
if you're a living donor, your life expectancy would go down, that is one of the things that they can consider.
Okay.
I think what this is trying to do is making sure that they can't deny or cancel or increase premiums. So typically,
So this is life insurance. So life insurance, you think about it, in the old days with health insurance, they would actually do a physical. They would, say we're not going to have any pre-existing conditions, okay? And we banned that with health insurance. But with life insurance, they're very interested in pre-existing conditions. They're very interested in all those things. And yes, the key thing is what she's saying is that only if they want to limit something or deny it, they have to have proof, the case studies that shows that
there has to be
is
actuarial
evidence.
Statistical evidence to suggest that this factor could impact your life expectancy.
Right.
And it's one of the factors. So where we say deny or cancel coverage, we wouldn't have an issue with that, because what would likely happen is your premium is going to go up. Reducing or limiting or making it so you can't increase premiums could be a problem for life insurers. I'm not going to speak on their behalf, but if you were to buy a life insurance policy, say when you're 30, relatively healthy, your premiums are usually, depending on the type of policy, you could probably expect your premiums to go up as you age, because your risk of dying increases as you get older. So if you have something that comes up, usually they don't underwrite your health again. But I guess if you were on some kind of living donor list that you had and they found out about it, that would be a mechanism for them to increase your premium. So that's kind of how this works. I wasn't here for the original hearing, so I don't know what the testimony was about, but
I'm pretty sure I was scheduling bills, so I was out of the room at the time. But
a lot of the other laws we see in other states are prohibiting unfair discrimination, but that would not prohibit the insurer from considering this in underwriting.
right.
They just can't use it as a sole basis for denying you coverage. It'd just be one of the many factors.
The issue is encouraging people to donate or to consider donating, and people are afraid to donate sometimes because they think they're not going to get life insurance and therefore protect the rest of their family.
They need to look at their life insurance plan before they decide.
Or they just might be thinking, well, if they're in their 30s, they might be thinking, well, geez, when I'm 50, I want life insurance. I've got 3 kids or whatever. And if I go give this donation now, I may not be able to get it later. Right. And
Well,
I
was looking at the sponsor and I see the Speaker of the House here.
Correct.
So I was thinking transportation, that when we renew our licenses, they always ask whether you want to become a donor.
organ donor, that's a deceased donor.
Right.
That's a deceased donor.
So that
Right. So this is your neighbor.
well,
needs a
isn't
kidney
life
or-
insurance about dying? In other words,
No,
can they say we refuse to give you your life insurance, your settlement because you had-
No. This is a living donor. This is a living donor.
This is the living
right?
donor. Okay.
So it's
okay.
you're going to be living with one kidney if you gave a kidney to your
right,
relative or a stranger. Who
and that
matched.
could potentially affect your longevity.
And there's always a shortage of organs. Like we know that. And like, I'm a little bit familiar with some of the sponsors' feelings on this, so I won't speak for him. But I believe he was a recipient. Actually, I think he testified to that.
Yeah, right.
Or he's quite familiar with it.
Okay, so the department would be okay. You're okay with one tonight or
We're
cancel?
okay with whatever you guys want to do.
The issue's in line
But,
10.
I mean,
think.
the
We want.
issue-
I want to. One thing I'm acutely aware when we talk about life insurance and property and casualty, which is not to confuse with health insurance, is one of the things we don't want to be an outlier compared to other states, because then our premiums would be higher and we would have less companies, less competition in the marketplace. So we don't want to be too crazy about how far we go. We want to be in the norm of what other states are doing.
I believe there's about a handful, I think maybe like 10-ish states who have passed laws similar to this, and they all focus around prohibiting unfair discrimination against living donors. And just to be clear, these are people who have actually donated and are still alive, not someone who's contemplating donation.
Oh, okay.
And it affects both, though. I think it affects the size of the likely donor pool. If it comes to your mind that you may impact your ability to be covered in the future, and therefore, provide that coverage to your family.
And the cost.
So, but underwriting is reasonable.
Yeah, so in the public hearing,
You've got to
John Hoffman, who is he? He says Nicoil. Does NCOIL have a policy on this? Have they-
I am not sure, but NCOIL is for legislators
Exactly,
promoting policy and not necessarily industry. So I'm not
yeah,
sure.
and how about NAIC? How about that? Would be
I
what
have
you-
not seen anything from NAIC on this.
nothing on the NIC.
No.
And that's where we really want to be on the same page with, because that really affects our premiums and our competitiveness in our market. Well, it sounds like we need to learn more about this before we get crazy. So how about interim study it, and so we can learn more?
How about we just take out increase the premiums? Those 3 words in line 10.
Reduce or limit coverage.
So they can still underwrite. And if between the parties, the donor and recipient, especially if it's familial, I think it's possible to overcome that underwriting. But I'm not sure we can prohibit underwriting.
I think there's more to that sentence, the reduce or limit or coverage or benefits or increase. Usually it's a trade-off. If
Right.
you don't want your benefits or if you don't want your premium increased, then you're going to have to agree to take a lower amount of benefits. So it's a little bit different. But again, I don't know enough about it to say too much more beyond that. But I would say just taking out the increase in premiums is not going to necessarily.
Well, you take
fix
out the whole
issue.
paragraph. If you
Yeah,
take
if
out
you
the
take
whole,
out the whole paragraph, then that's
okay, so let's see what we leave. Preclude a covered person from donating all or part of an organ as a condition of receiving or continuing to receive coverage under. So that's kidneys, right? Because that you give part. Receiving. Okay, so do we want to leave that in there? You get liver, part of your liver, right? They do that. Okay, so how many lawyers do we have in the room? So
don't know anything
any
about
other
kidney
paragraph you would
transplants.
want to remove? Anything else? I mean, I don't want to be too off the reservation when it comes to other states and passing this legislation. Do you want more time to?
Yeah, I mean, if you want to think about how we can tinker with this, I can take it back and do a little
Okay.
bit more research on it. I know that what I'm not seeing here, which I did see in a lot of the other ones, was the phrase "the unfair discrimination." So I'd want to see if that's something that we want to put in.
Okay. Right. So you want to use more language that other states have used.
Yes. So I
Okay.
can take it back and look at
Okay.
some other states.
Yeah, we don't have to take action on this yet. So
19 states,
yours?
according to quick research.
okay.
But I would caveat that
And-
it's
No,
not the same
we're not
bill in
gonna
all
interrupt.
19
We're gonna-
states. So
we're
it
gonna-
could be very different in what has actually
I'm
passed.
sure
we're
it's
gonna
not the
need a
same, but
res-
19 have something and 3 have pending.
Okay, we're gonna reschedule and wait for the department to come up with a standard language for.
Yes, that would be more in line with what the majority of states have
Right.
done. that
Very
have passed
important.
this.
Okay. Is everybody okay with that?
Yeah.
All right, great. Okay, relative to contracts between public adjusters and the insured. Didn't I thought we were going to take care of. Then we weren't going to dispose of this. Anybody here for this bill? Where's George? What happened to Henry? What happened to all the lobbyists for this bill?
The insurance department recommends ITL to enable
Yes.
further review.
Yeah. Okay.
Yeah, that's what we want.
Okay.
I can confirm that.
All right. Anybody want to make that motion? Okay, Purcelli. Okay, Representative Purcelli, seconded by Representative Hunt, moves in expedient to legislate in 1257. Any discussion on the motion? Seeing none, the clerk will, excuse me. All those in favor, please say aye. 1, 2, 3, 4, 5. Okay. And last but not least, all right. Are we okay with this amendment? I know I gave it to, did you get a copy of this amendment?
Yes, we did receive a copy of the amendment. My name is Keith, and I am the Deputy Commissioner at the Insurance Department. Happy to answer any questions you have.
I think we all get it. It's pretty clear. Just, we don't need to have the glass man who comes into it. I always love it, the fact that they drive to your house and put that glass in right there. To me, I love that. So, but to make them an insurance adjuster would be insane. Yes. Okay. So, but everything else in the bill is correct. Is that right?
That is correct, Representative.
Yeah. Everything else is. Well, this is only the subcommittee members need to get it. So, not everybody needs it. Yeah. I'm sending it over. It's because these two are hogging the amendment when they don't need to. You can just read it. You're not on the subcommittee. This needs to get to the members. Okay. You were just always suspicious of what's going on, right? Okay. It's okay. Anybody want to make the motion? The vote to pass on this amendment? Okay, I will. All right, I move out to pass on the amendment. Any discussion? Sure, Representative Burrows, seconds. All those in favor say aye. 1, 2, 3, 4, 5. Okay. I'll move ought to pass as amended. Any discussion on the motion? Seeing none, all those in favor say aye. 1, 2, 3, 4, 5. Okay. All right, so the only one we need to come back for is the living organ donors, and we'll get that standardized. Okay, we're all done.
It's just for my records.
Just put these in a different file.